We're trying to get set up here. So glad to see you joining us today. Thank you. We'll give it just a minute or so to let people wander in. A lot of people, we know all of you joining understand that our lives are chaotic, and so we join if and when we can. And so, no worries, you will not be on screen. We can't hear you. If you are managing a screaming child or laundry or anything else during this time, feel free to multitask. Everything will be recorded and up on our website soon. So let me just give one more minute and then I think we'll jump in. Feel free to jump in the chat, introduce yourself, say where you're joining from. I see some friendly names here that I know well. Hi, Marissa. Hi, Megan. Glad to have you with us. Yeah, feel free to jump in and during the webinar, if things are resonating with you or you're feeling like you need a little more explanation about something, feel free to drop that into the chat. If you have questions, we also have the Q&A feature open, which you can use. We'll mostly hold questions till the end of the session after we hear from both our caregiver experts and our clinical expert, and then get into questions and open discussions. So hope you can stick with us. Today is going to be really an amazing chat. I've already seen how it's laid out, and I'm really thrilled. I always forget to introduce myself, so I'll do that quickly before I hand it over. My name is Gabi. As you can see the picture on the right there, I am mom to Elliot, who is about twice that size now. He's 13, has a beard. He has SCN8A, and he's really profoundly impacted by his DEE, and started DEE-P Connections as really a place to build community and resources and information and empowerment for families like ours who I know this can be incredibly isolating, and we want to make sure that wherever you are on your journey, you have the support you need. So, as always, feel free to reach out anytime, all the time. Shannon, I'm going to hand it over to, does a lot of our programming and outreach. You'll see her posting online and responding. So, we're here for you. Thank you for being a part of our community. And I'm going to hand it over to Shannon to kick us off.
Awesome. Hi, I'm Shannon. I run, like Gabi said, I run the programming at DEE-P and help plan the webinars and social media and all things kind of just involving the community. My daughter Zoe passed in March of 2024. She had an ultra rare condition called CRELD1. But I'm so honored to carry her legacy on, and hopefully that further down the road, families can experience better quality of life with their kids and longer lives. And so, yeah, I'm so happy to be here and so honored to still share her story and help families like ours. So, but I'd love to introduce our parent panel, Lindsey and Brittni, longtime friends. I feel like we've been friends for a long time online.
Yeah.
And me and Lindsey met in person in real life. Me and Brittni still need to, but I don't know who wants to go first. I guess I'll pick on Lindsey. We'd love to hear your story and all about little Huddy and your guys' journey um, with pulmonary decision making, but also just his life in general. So
Yeah.
take
Okay.
it away.
So I'm Lindsey Garret. My son is Hudson Garret. He is 6 years old. He has a diagnosis called hypoxic ischemic encephalopathy, which is a very long term. That just means he went um, without oxygen or blood flow to the brain surrounding birth, and it ended up in a brain injury. Hudson's number one thing that we've battled throughout his brain injury, he is severely disabled, but the number one thing we've battled with his disability is our pulmonology, our pulmonologist. We see them more. We see ENT, we see pulmonary, all that stuff. Our day to day looks like the shaky vest, the cough assist, trach care, nebulizers, inhalers, all the things. And that was a big decision for us to move forward with the trach. But it kind of was a process. We didn't just get there overnight. There was multiple hospital stays, most of them being in regards to like pneumonia or his floppy airway or airway obstruction, things like that. So I'm happy to be here today to kind of share our story. It was a big decision for us to move forward with the trach because we don't have nursing. So we knew it would just be us. That's because we live in a area that doesn't have a lot of nursing, especially for pediatrics. So that was, for a long time, that's kind of why we kind of fought against the trach. We did everything we could before we got there. So like the sleep studies, we tried CPAP, we did all the things, all the preventatives, and still we ended up here. But how we ended up here, I will say, was because we had a doctor that we trusted, and we kind of just sat down with him and asked, do you think this is what's best for Hudson? Because it kind of got blurred for me being like right there in his small circle. All I could see was what extra it would add as far as like care and things like that. And it seemed like it was very overwhelming for me to make that decision. So I very much appreciate having someone on our team that we can talk to that helped us make that decision. But it took us a while to get there, for sure.
Yeah. Tell me like one of Hudson's favorite things to do. And I know he loves his little brother too. So we'd love to hear
Yes.
those things.
So we call him our little old man because Hudson likes his TVs, his Disney movies actually, and his chair, and you better not get in his way or he's yelling at you. So we call him our little old man, but he also loves when it's warm to float around the pool. We have like a specialized float, and he loves to be out in the pool. And then we also have like a little buggy that we ride around the yard, and he loves to do that. He actually told us the other day he wanted to do that. So he's very all boy. He likes to be outside. He likes to be dirty. So,
and he's using his eyes gaze device.
Yes, that's new, but he is definitely learning it really, really well, really fast. Yeah,
it's so cool to be able to give him a voice. So
yeah, he's been doing really good with it. We're actually trying now to add stuff to it, like in regards to his care, like when he's ready to do his trach care and if he needs suctioning and stuff like that, which obviously we know when he needs suctioning, but just trying to give him a voice in his care.
I love that. That's really cool.
Yeah.
Well, so glad to have you here with us, Lindsey. Okay, Brittni, take it away. Tell us all about Icy Pop.
Okay.
No, I know that's a nickname.
Well, that's what he's known by, so we got to go with it. I'm Brittni Evans. My Isaiah, Icy Pop. So his initials are ICE, and his brother's only 13 months older, and so that nickname stemmed from that. And now for our epilepsy walks and everything, we're Team Icy Pop. So Isaiah will be 7 next Thursday. Sorry, and when Lindsey talks about her kind of journey, it's very similar. One of our biggest, if not, one of our biggest has been Isaiah's respiratory needs and how they've evolved, unfortunately, in a lot of ways, gotten worse and all the things as he's gotten older. We are just now, within the past year, learning more about the genetic mutation. It's UNC13A. We're still learning about it. It falls under a congenital myasthenic syndrome, so neuromuscular, which makes a lot of sense. One of the other big areas that does impact his respiratory needs so greatly is his neuromuscular scoliosis. And that's what's really kind of catapulted his respiratory journey. We just started out, when he was a year old, needing supplemental oxygen for prolonged seizures. And then by 2, he was BiPAP dependent, but he also had a curve of over 70 degrees. So at that point, we did start talking about trachs just because of how quickly everything was progressing. We did fight back at that point. And I will say, what he needs is always our number one, but that's a big, like Lindsey had shared too, it's a big change. And I just felt like at that point, we could potentially do more. Or something different rather, not more. So he had a phenomenal orthopedic surgeon he went into halo traction at 2 years old, the youngest at that point there to do that, and then had magic rods placed. We unfortunately had a lot of wound issues and infection issues, so those had to be removed, and the curve then grew so fast that he had to go back into a halo, and that was last spring. And he tolerated the halo beautifully the first time. And last spring he didn't. And we don't really have an explanation for as to why. So over the course of almost 4 weeks, he failed 3 extubations, excuse me, and had to be urgently intubated. So then that's when the discussion of our decision really came into play as to what's next. And we could either not, choose to do anything, or go for move forward with the trach. And at that point, that's absolutely, what we wanted to do. I've always said, and it's difficult, but that Isaiah is leading the way. And I just felt like that was not our our end moment. So we didn't have a lot of ability to make decisions about it. It was either that or not. And so we did. And it's been rocky, but it's been a huge blessing. And I will say too, we do have some nursing available, but he's not more medically complex than a lot of other kids, but he's very tricky. He will desat to very low numbers, and he'll do, things that you can't just have anybody come in. So we've been blessed with some night nursing, but I am doing the care during the day, and it's just so much easier that way. And you're just kind of thrown into it, and you learn quickly. But it also, to have that stable airway, and he had a really rough fall with more orthopedic issues, and to know he could come out of a procedure and not have to worry about being extubated just made a really huge difference. So it was tough getting to where we got to, but now that he has it, I'm very grateful for it.
Yeah. Okay, tell us some of his favorite things.
So Isaiah loves balloons, absolutely loves balloons, loves Mickey Mouse. I had a disabled brother as well who passed away right before Isaiah was born, and he loved Barney, like the old school Barney. And so I brought that back, and Isaiah loves that too, which is just really sweet that they have that. And he just loves people. He loves his brother. He just loves being talked to and included, and he's just really joyful.
Love that. Thanks so much for sharing. Glad to have you both here, and
Thank you.
they'll be back after Dr. Caylan does her talk to answer questions. So if you have any specific questions for them and their journey, throw them in the Q&A. But I'll hand it over to Dr. Caylan to educate us on all things pulmonary.
Thank you so much, Shannon.
Yeah.
So I am Esra Caylan. I'm a pediatric pulmonologist at Cook Children's Medical Center in Fort Worth, Texas. And I am actually new at Cook Children's in a couple months only, but I was at Dallas Children's and before that in Massachusetts. So it's been a while in the pulmonary field for me. And taking care of children with neuromuscular disease is actually my main area of interest. They are awesome, but they have a lot of like respiratory complications and pulmonary problems. So we became very close friends. We see these patients more than their pediatrician or mostly any other subspecialty. So I'm very happy to be able to here with you today and tell you a little bit more about what we do in the pulmonary care for taking care of these patients. So let me start to share my slides. Okay, hope everyone can see the slides.
We can if you just, go for it. It's great. Looks awesome.
Perfect. Okay, so initially I want to start, what are the challenges like we are seeing with the patients with like deep or like neuromuscular diseases. They are like, the breathing is multifactorial controlled. It is controlled with the brain, muscles involved, your lungs involved. So there are so many things we can get wrong, like airway involved. And then with taking, like when you have any syndrome with DEE-P, the brain control gets affected. It's because there is regulation with the muscle control, breathing, so respiratory function gets affected. Neurological effects get into account because there is muscle weakness, and breathing is muscle dependent. diaphragm, intercostal muscles, abdominal muscle. So you need to use your muscles to be able to open your chest and get the air in. So it is completely muscle dependent, and anything affecting your muscles affects your breathing. Coordination can get affected because there is the timing and the effectiveness of the breaths gets disrupted in between the brain control and the neurological effects in the periphery. And then there are some swallowing difficulties. So I know swallow is not part of the lungs, but it is so close to lungs and it can cause lung damage, unfortunately. So children with swallowing difficulties face risk of aspiration. And this can lead to chronic aspiration and can cause chronic respiratory infections or recurrent respiratory infections. So unfortunately, once a foreign body gets into the lungs, there is no way out. So it sits there, cause problem, infection, or if it is a big particle that needs to come out. So that chronic aspiration and the recurrent infections comes to the point that they can cause lung damage and make initially difficult breathing even more difficult. And recurrent pneumonia, either it is caused from aspiration or just because they are prone to get like recurrent infections, viral infections, bacterial infections, recurrent pneumonia is become a problem because it affects the lungs. In short term, yes, they need to go to hospital, get recurrent antibiotics, which can cause resistance to antibiotics. So you need to find new antibiotics to treat the infections. But also in the long term, there will be some permanent damage to lungs. The lungs can get more stiff. There will be bronchiectasis, which means that the airway gets enlarged and they cannot get back to normal size. And those spaces becomes pockets of mucus, which prone to get bacteria to overgrow and cause more infection. So we need to be more proactive to prevent infections to avoid to get into that vicious cycle, which is unfortunately more difficult to do than just say it. Upper airway issues. I think, Lindsey, you mentioned that like collapsing airway obstruction, those happen. So airway Malaysia is really floppy airway. So the muscles and the cartilage is not strong enough to keep the airway open when our patients are breathing, taking a breath in and out. So they close. And when the airway closes, that means that they don't have enough space to breathe. So it becomes a problem. That can cause with anything obstructing their airway can cause sleep disorder breathing, which means that when they are sleeping, they're not breathing efficiently. So any of us, when we sleep, our muscles get relaxed. So we take more shallow breaths. We are not taking very deep ones. But if you're already taking inefficient breaths when you're awake, when you get to sleep, this becomes a problem. It can cause sleep apnea. It affects the sleep quality. It can cause hypoventilation, which means that the work of the lung is not efficient enough for your oxygen and carbon dioxide to get in and out to your body. And secretions. So cough. As I said, breathing is muscle dependent. Cough is same. So the coughing is like, when we cough, it is something forceful. You use your muscles, you use your breath to make a forceful breath out to get the secretions out. And unfortunately, with patients with DEE-P, that cough gets affected and it's not an ineffective cough. But the cough is your first defender of your lungs. So you need to get that secretions or any foreign particles out of your lungs with a cough to be able to keep it clear. But once the cough is not effective, it causes increased aspiration risk and then increased infection risk. Drooling is another problem. With the DEE-P, mostly the problem is not producing the saliva a lot, but it is the control of the saliva because there is swallow dysfunction. So whatever saliva is produced, they're not able to swallow it very well. Or because of the, like, they are not able to close their mouth completely or open their mouth completely. The tongue is too big. Jaw position is different. So they all affect where the secretions are pulling, and then they cause drooling. So one thing is drooling coming out. Yes, it's difficult because you need to like clear that. But then those pulled secretions can also go to the back of the throat and can also cause aspiration. So it is in both ways, it will cause a problem. So what do? When we start to see our patients that we know who can have all these problems? Swallow studies. So when there is any sign showing that they have difficulty swallowing or risk of aspiration, we do get swallow function test because we want to be sure that they're not aspirating. And then we start with chest x-ray initially, but it does not give us a lot of information, but it's a good screening test. So like when a kid is doing well and we are seeing them regularly, we do get maybe once a year chest x-ray just to keep an eye on lungs. What is happening? Are they expanding enough? Is there any chronic changes happening? So that will give us some information. But when we need detailed information, if the kid is having recurrent symptoms and like more worsening problems, then we may need a CT or an MRI to get the structural airway and the lungs evaluated. And bronchoscopy. So bronchoscopy is the procedure where we go in with a like tiny tube with a camera at the tip so we can look around. It shows us the airway. I do not go into the lung tissue and is not able to see the lung tissue itself, but the airway we can evaluate with a bronchoscopy. So it will show if there is floppy airway, if there is any narrowing, if there are any like increased secretions or thick secretions that we need to address, or any anatomical abnormality that we need to know that can cause different part of the lungs much more prone to get infected. Sleep studies, they are crucial because like it is difficult to catch these signs when you have like signs of the sleep disorder breathing when you already have a like neurological disorder. So the signs of the sleep disorder breathing are patients feeling tired, sleeping during the day, or like some headaches. But either sometimes communication is limited or sometimes the disease itself also causes these symptoms. So you need to have low, like very low suspicion for the sleep disorder breathing and get early sleep studies to catch any hypoventilation, sleep apnea, or any abnormality with the sleep or the breathing. And then sometimes the reflux can cause upper airway inflammation. So we want to be sure that it is not causing a problem. So even if the patient is getting feeds through the G-tube, if they don't have any sin, you can still have a reflux and then aspiration risk. So that will be a time that you need to test that they're not having reflux problems causing, like affecting their lungs and the airway. The oxygen and carbon dioxide monitoring, it usually starts in the hospital. When they are in the hospital, when they are sick, those are the things that we monitor. But then comes like to time that you might need to monitor this at home. Not usually the carbon dioxide, but the oxygen, because like seizure disorder or like lung disorders, they might need oxygen at home. And that like oxygen monitoring can tell us whether their oxygen needs are going up, their lung disease is getting worse, or is it stable enough to just continue to watch? So it will be a good information to guide us what will be the next steps. Sorry, let me get this out. And then, well, before starting the non-surgical support, I want to actually say that, so those are all symptoms which can start early in life or later in life. But as a pulmonologist, I actually want to meet my patients before they start to have symptoms. So I know you already see a lot of doctors. Like you start to see the pediatrician and then the neurology comes early. But usually we try to get these, like get to meet with our patients and the families before they start to have problems. Because the more we can protect the lung, that means that we can delay all these complications more. Or at least we can try to delay those complications more. As I said, everything I'm saying here, I know that it's easy to say, easy to summarize, not that easy to do with each patient. So each patient is unique and they show us what they need for that. So the non-surgical support. So I think it was Brittni or Lindsey, one of you mentioned that it's the cuff assist, the West, nebulizer, medications. Yes, exactly. Those are all the techniques we try to get into the part that we can help with the secretion clearance. We can help with the cough. We can help with the pulling of the secretions, of the drooling. But so they work all together. Which one you need depends on what part of the lungs or the muscles get affected and what kind of symptoms patient is having. One of the things we use is the chest physiotherapy. So we usually start with the manual chest physiotherapy. We'll show you how to pat really effectively and then like position them, do some positional drainage. But it's usually when they are younger. When they get older, it's difficult to continue to do that. So then it comes to chest, like West, we call it. It's a high frequency oscillation device. So it's what it does is it's really you put the West on and then it shakes up. So when you shake the chest, it shakes down the mucus off of the breathing tube walls. So the secretions are easier to come out. Because the secretions sit on the walls much more longer, they get more thicker and they get more sticky. So it gets more difficult to get them out. So our goal with the chest physiotherapy is move them off of the wall so we can get them out. So, and then it comes the cuff assist device. As we said, cuff is the initial defense mechanism, right? We need an efficient cuff, but if you're lacking the ability to produce that cuff with the neuromuscular weakness, here comes the cuff assist device. It's a device, it's a small device, comes with a hose and a mask, and it literally mimics a cuff. So it gives you a big breath, then holds it, and then it suctions it out. And this is exactly how we cough. We take a deep breath, hold it, and then forcefully like exhale it out. So they put it in a machine. And the machine, you can adjust the settings, adjust the pressure as the patient is like getting older or during the illnesses or when they are feeling well. The pressure can change, but it is a high pressure. So whenever I start a cuff assist device, I always recommend my patients' parents to use it on good days too, because we're talking about a very high pressure to push the air in and then suction it out. The suction part is usually even more uncomfortable. And if you introduce this device the first time during an illness, there's going to be a lot of fight with it. So it works better if you can just do it daily, become a part of the daily regimen. So patients like your kids can get used to it and feel comfortable with it. So when they get sick, you can use it more frequently. And when I say more frequently, every 2 hours, every 4 hours, whenever they think that they need to cough, you can use the machine. And so we put the West on, the secretions are off the wall. We did the cuff assist device. The secretions are up on the upper, like larger airways or back of the throat. They still need to come out because it's not like there's swallowing dysfunction also, right? So we do not want those secretions sitting on the back of the throat. So you need to suction them out. So suctioning is the last part, but it's also important to finally get the secretions out. And then, of course, medications. So medications can be in different parts. One part is the inhaled medications that we can use before the West or during the West therapy to lose up the secretion. So there are different ones we use. One is albuterol. It is a bronchodilator, which means that it actually opens up the breathing tubes, so there will be more space. And then there are mucolytics, which means that they break down the mucus. And one of them is hypertonic saline, which is really like salty water. Like there will be different concentrations of that, but that salty water inhalation medication helps to lose up the secretions. In our body, water follows the salt. Wherever salt goes, there will be more water come out following it. And when we give the salty water, we are bringing more water to the secretions, so they get looser and they get thinner. And then there are different ones that you can also use, but the most common one is the hypertonic saline we use. And then about the drooling, there are some medications we use, which is a little tricky. So there are some local medications we use, like the atropine drops or the atropine spray, which is mostly effective in the mouth, and which is good because they have less systemic side effects, but unfortunately they're not very potent also. And then it comes the glycopyrrolate, which is a medication, which is a systemic medication, and then it decreases all secretions, but it comes with the risk of, if you make the secretions very thick, then it will become more difficult to bring them out. And also it can cause urinary retention. So if a patient already have some urinary problems, you need to be careful not to make it worse. So you need to find a balance here to control the secretions, but not make them too thick, so it will be difficult to get them out. And then Botox injections, this is to reduce the saliva production. So if they do not respond to the medications like the ipratropium, atropine, or glycopyrrolate, then the Botox can be one option, because that will decrease the production, which will help you to decrease the drooling and the pulling of the secretions. And non-invasive ventilation. So it is CPAP or BiPAP or AWAP, so like different modalities coming, but it is really just using the ventilator, but with a mask with different interfaces to give some pressure. You can choose different modalities for that. CPAP is the one that you have one pressure, you keep giving the same pressurized air to keep the airway open. It is much more efficient when you have like a floppy airway or like some airway obstruction. So you want to keep the airway open, so you want that pressurized air all the time there. And then if you have problems with the lung not able to function very well, which we said hypoventilation, the BiPAPs or the other modalities come in, because they have two different level of pressures. There is a baseline pressure, keeps the lungs open, and then like we are breathing and opening our chest, there is a higher pressure, opens the lung and then closes. So that helps, and this is something we initially start to use during sleep or when they are sick. Sleep, if they have the sleep disorder breathing, they got the sleep study, they might have this titration to see what kind of machine they need. Do they need a CPAP? Do they need a BiPAP? And what are the pressures they need? Sometimes when they come to hospital with an illness, we won't be able to wean them off of the BiPAP completely or the CPAP completely. Then those times will be the times that we might need to send you home with a machine, and eventually we'll still get a sleep study to confirm the settings and also get the insurance approval, continue to use the machine. And even though we are starting to use the ventilation machine during the sleep, that actually becomes something that you use when they are sick. You will use it while they're awake also during the day. Maybe there will be times that you need to keep them most of the day on the BiPAP and then give some breaks during the day. And then as they are getting better, you may wean too. And when it comes to the point that you cannot wean them off of the BiPAP, then comes the other conversations that we are going to talk. So I think one of the conversation is surgical interventions we wanted to discuss on this webinar. And I know when we say surgery and the pulmonary, the first thing comes to my mind is the tracheostomy. But there are actually other procedures we like get involved to help with the lungs and the breathing, and the tracheostomy is the last resort that we might need to follow. So adenotonsillectomy, this is even common with like kids without any neuromuscular disease. If you have enlarged tonsils, if you have enlarged adenoids, they can obstruct your airway and they can cause sleep disorder breathing. They can cause obstructive sleep apnea. So you want to like open this airway. So removing the tonsils or the adenoids can be one option. When you have floppy airway, supraglottoplasty, which is a way of airway reconstruction. So they just like do some surgery to make that airway remain open when the patient is breathing. So that can help with that floppy airway, because as we said, the floppy airway is closing on you every time you take a breath in because the pressure is sucking everything in. So supraglottoplasty helps to keep it open. So it will be one way to avoid any other further surgeries or delay until you see they need it in the future. And we talk about drooling, we talk about medications, we talk about Botox. Sometimes they all fail. And when they fail, you might need to do some salivary gland interventions, which means that you might need to remove some part of the salivary glands to decrease the production, because kids are not able to control the secretions, are not able to tolerate all that drooling and the pulling of the secretions. So the G-tube placement, I know, is completely GI, and Dr. Mansi talked about that on the other webinar, but it helps us because it helps with the aspiration. So if you cannot feed a kid safely by mouth because they are aspirating and they have swallow dysfunction, you need a way to safely continue to feed them. So G-tube placement helps when a kid has the aspiration and swallow dysfunction to protect the lungs also. I know it helps them to continue to feed and grow, but it also helps to protect their lungs. And we come to the tracheostomy. So I think, Brittni, you said that like at 2 years, they offered you the tracheostomy and you fought back. And this happens. And it actually goes two ways. So sometimes the medical team offered that and the families does not want it. And sometimes it goes the other way. The family wants it, but the medical team fight back. So this conversation is not always an easy, okay, do you want a tracheostomy, yes or no conversation. There is usually a lot of going back and forth. Sometimes it's very clear, everyone is on the same side, same page, and it will go. But I think it's important to be able to understand each other. And also remember that we all trying to find a way to help our patients or the kid who is not able to breathe at that time. And everyone's understanding is different on that. And we are looking at the data we have and the medical knowledge we have, and families looking at every day what this kid is doing and like facing challenges. So we need to come together and understand each other to in every step of this care. But when you have a big decision like a tracheostomy, it becomes much more important, because starting a medication is easy. I can start the medication on the hypertonic saline, and if they don't tolerate, I will stop it. Putting a tracheostomy is different. You will put a tracheostomy and you are like, with the patients with neuromuscular disease, with DEE-P, this like you're not, this tracheostomy is not reversible. So it is a big decision, and it is important that when we come to the table, we are open to each other. So when the tracheostomy comes, so we said hypoventilation. So that means that they're not able to breathe efficiently. It can be because like combination of the muscle weakness, the brain control, their seizure disorder is getting worse, their like muscles are getting weaker, anything affecting, and that means that they are not able to breathe efficiently and they need support on that. Airway obstruction. We talk about supraglottoplasty or airway reconstruction, but sometimes the malaise or the flappiness is very severe. Those procedures will not be helpful enough. So you need to keep that airway open. So you need to kind of like put something in to overcome that obstruction. Anything affecting airway clearance, ineffective cough, or secretion management difficulty. So we talk about the chest vest, we talk about the cough assist and then suctioning. Let's say we are using them, but we are not able to suction the secretions. The secretions are still stuck in the upper airway. We cannot suction that deep. We are just suctioning the back of the throat. They still need to do the job to be able to bring the secretions up there. And if they don't, they cannot do it. And if it is causing recurrent infections, recurrent hospitalization, then tracheostomy can be an option because that gives us direct access to the trachea, the main breathing tube that we can suction out. We try non-invasive ventilation, and if failure of that, which means that it is not efficient enough to overcome the breathing problem, or patient is not tolerating that because they're going to have a mask on their face at least all night, right? Or even when they are sick, longer than that. And that mask, sometimes it's not comfortable. Sometimes it causes skin breaks. There will be pressure points. We tried different masks. There will be masks covering the mouth and the nose, just the nose, under the nose. There are different masks, but sometimes they do not tolerate any of it. And then it will be part of the failure also. Hospitalization. We are doing everything we do, but the kid keeps coming to the hospital because of any of these results. And then I think that will be that is going to be one of the conversations you will hear. Do we need a tracheostomy for better airway clearance, breathing more efficiently? So it is the last result. But it is the last result. It needs to be a last result for, as I said, for the parents and the medical team also. Maybe medical team thinks that, oh, this kid can be on the BiPAP for longer, but the kid does not keep the mask on. Every night you need to stand there, hold it on his face. It is not manageable. That means that you are still at the last result. So it can be either way. And for preoperative phase, you will meet a lot of people. Pulmonology is going to be there. ENT or surgery, who is going to do the procedure, will be there. And then neurology is already there. It is really mostly to see if the patient is at baseline or this is an acute deterioration. Are they going to get better? What is the expectation? And then you will need the trach educator team. They will come and tell you the whole process. It depends on where you are, your facility, but most of the big hospitals now they have a trach educator team, and they come and explain you what is the procedure, what to expect after the procedure, how long you will need to stay in the hospital, and then what you need to do. So, and then it's going to be a team discussion. So we were talking right before we started. My husband is a palliative care physician, and I need to tell this here that palliative care is going to become a part of this team, and they're going to help you to negotiate between the medical team and you actually, and no, like just to get everyone together. And then I'm not getting into the procedure itself. It is the surgical part, but what is happening afterwards? So once you have the tracheostomy put in, no one is touching that tracheostomy for like 5 to 7 days. The patient is in the ICU, mostly sedated and keeping calm. And then the surgeon will do the first trach change, be sure that it is like there's a good like easy way to put the trach back in. And then you come to the mostly the pulmonary service or a training service, because we need 2 caregivers to get trained to completely take care of that tracheostomy and the ventilator. And the reason is, as Lindsey and Brittni both said, unfortunately, we do not have enough nursing. Nursing is a big problem, and it is bigger problem depending on where you live. And it became a bigger problem after the pandemic, actually. And then sometimes you have approval of 24/7 nursing from your insurance because your kid has a tracheostomy or ventilator. We will get that approval. That's not a problem. The problem is filling those hours. Find someone really personally come to the house and take care of your child. And not everyone is pediatric nurse, and not every pediatric nurse feels comfortable to take care of a complex kid. So we need 2 reliable caregiver to be available, because one of the caregiver can get sick or get busy, so there need to be another one to get trained completely. And that training is, you're going to show how to do the trach change, how to do the suction, how to address the alarms on a ventilator, and how to apply, like give the medications. And you're going to show efficiency doing all of this in the hospital before you can go home. So it's not like having a surgery and then in a couple days going home. Sometimes you might need to be in the hospital for a couple of months. So it depends on how quickly you can get that training and show efficiency. And even that, let's say you got the trach done, you went home or even the hospital. It is like, yes, we have the trach tube, and then we have ties going around the neck to keep the trach tube there. But it's still a tube and it can get dislodged. So it is always a problem, because now our patient is dependent on this airway to breathe, right? We know that they are not able to breathe efficiently without this tube. So it needs to be like easily able to put it back. And sometimes it's like very quickly, because the cartilages and the tissue, they want to close on you. So it's important. When you have the trach tube inside sitting on the breathing tube wall, sometimes it can cause some irritation and granulation tissue, and it can cause some obstruction. So you need to get evaluation and then get that granulation tissue out. Infection is still a problem, because sometimes the trach area can get colonized with different bacteria, and you can have now different infections that you might even need to use chronic antibiotics. There are times that we need to use an inhaled antibiotics every day for some of our patients, because we need to keep that bacteria suppressed and under control to not cause active infection. This is one thing I always be sure that the parents hear before they make a decision. So I know, like, not all of our patients with DEE-P talk or communicate completely, but they make noises. And for most of the families, that noises means a lot, actually. They can understand their kids from their noises, what they want, what they need, or even like there will be some communication to get like in between the kid and the parents or the family. When you put the trach, you're gonna lose that voice. There are some valves eventually you can try later, but with the neuromuscular weakness, it is more difficult to tolerate those valves. Or sometimes when they are able to have some air leaking around the trach, they may start to make voice. But there are definitely going to be at least some time you will not be able to hear the voice again. And I want to be sure that any of the parents of my patients know that, and it's not going to be a surprise after the procedure. So I've been saying that it is really shared decision making. And as I said, it is 2 ways. It's families and the medical team. We need to understand that we are in the same team. We are the team, whatever our patient's name, and we want to do whatever is right for that patient. And it's always important that you feel comfortable asking questions. So even if you met your pulmonologist recently and you need to get into the conversation with tracheostomy, be sure that you're asking your questions and you have a trustworthy relationship, because they are going to become very important part of your life. You're going to call them in the middle of the night sometime saying that there's a problem with the machine or there's a problem with the trach. So you always need to feel comfortable to ask questions, and our part is really encourage these questions and answer all of them. So it will be an informed consent, right? When we get the consent, it is called informed consent. So you get all the information you need to make that decision. And then in long term, it's ongoing assessment. You get the trach, you went home, you're still going to come back and see us. If everything going well, it is every 6 months, but it can be more frequently. And then every time you come, it is going to be a little more detailed like work now. You're going to get a blood gas. We're going to check the vent. We're going to check the machines. We're going to get a download of the machine. What is the data in the last 3 months? So it is going to be a little bit more detailed and a long visit when you come back to see us after a tracheostomy, which you want to also, because you want to check everything and ask all your questions also. And it's still not going to be only pulmonary. You still need your pediatrician. You still need your neurologist. You still need to get everything checked. We keep talking about the infection. So infection control still a problem, and just regular vaccines is going to still important for you, for the patient, for the family. And then the coordination. So I do not know how many subspecialties each of you are seeing, but it's many, many subspecialties. So we need to be in contact with each other when there's a concern to be able to like reach out and say, okay, so this kid is G-tube is malfunctioning, there is reflux. I need to talk with the GI when I'm thinking that patient is refluxing and still having aspiration and it's affecting their lungs. So it is like really important to have a coordination of in between subspecialties. And our goal is really try to keep them home and with a good quality of life. They are comfortable and they are at home. All the things that we are doing, that's the main goal actually. So hopefully with all these interventions can help them to stay at home. Even if they get sick, you will have things that you can use, the treatments, the machines you can use to control that infection at home. If not, of course, you will still come, but that the goal is to manage everything at home so they can stay at home and they will be comfortable when they are at home. And I think that is all I have.
Amazing. Thanks so much, Dr. Caylan. If anyone has any, I don't see any questions right now. Probably people are processing, I'm sure. It's a lot to take in. But if anyone has any questions, please drop them in the chat or the Q&A. We've loved having you. And Lindsey and Brittni, I'd love if you guys have anything like to add, or did you learn anything? I'm sure you guys are like pros, but sometimes parents they go, oh my gosh, I wish I would have known we could have done that surgery or done this or that. It got skipped over in my kid's case or whatever. So I'd love to hear from you guys while we're waiting on any questions to come in.
I loved that you spoke about the voice. That was such a hard thing for me with Hudson. I feel like a lot as a special needs mom, a medically complex mom, that we've already lost so much, like we've grieved a lot of our child. So the trach, I'm glad you brought that up. That was a really hard part of our decision making with the trach, because Hudson is known for his smile and his coos and his tone. And a lot of the way that I know how to care for him is the tone that he uses with his voice. He doesn't talk verbally, he doesn't use words, but he does communicate with his tone in his voice. And so that was something that was really, really hard for me, especially not knowing whether he would be ventilated or not. Would we ever be able? I know early on people talked to us about a talk valve. we didn't really know if that would ever be part of his journey, if he'd ever get to where he was strong enough to be able to like kind of tolerate that. And he has here and there, but not long term. So I'm glad you spoke on that, because that was a big part of our journey, was losing his voice. It felt like one more thing we were losing. So not only did the trach feel like more was being thrown onto our plate more medically, but also it felt as if we were losing more of Hudson. I will say we did not. We've gained more of Hudson. He's more awake during the day. He is so awake during the day that now we're able to trial things like the eye gaze and work on that. And we're able to go to therapy because we're not battling with positional airway where we can't even get in the car seat safely. So we did gain a lot of Hudson back with the trach. I will sing the trach's praises all day long, but I don't know everyone's story and why they're making this decision. So I can't say it would be that for everyone, but I am so glad you spoke on that, because I feel like sometimes we focus so much on the medical side of the trach and we lose like our kids' personality in the span of it. So I'm really glad you spoke on that, because I think that's something for people to think about if they're thinking about a trach, for sure.
Yeah, for sure. Brittni, anything to add? And then we do have a couple questions.
I mean, similarly, just to Lindsey's point, and Isaiah will, so we've tried the PMV, and he's actually done surprisingly really well. I say surprisingly because his health overall last year kind of really took a hit, and so not knowing, quite what to expect, but because we had such long hospital stays, I guess a benefit was that we were able to trial that inpatient with a speech therapist. But it's, and again, we kind of made our decision a little bit, our point of getting there was different at that point, but his trach is cuffed, and whenever there's a little bit I can tell when he, which is a little bit of Isaiah back too, so to that point, it just is so nice. He'll start making sounds because he's figured out that he can. And unfortunately it means he needs more water in his cuff. So I hate that, like, I have to take that away from him, but it's just really cool to see. So I will, like Lindsey, I'm going to sing the praises too, because it's given us a lot back with him and a lot of stability that we didn't have, but it's a big overall deal. Yeah. So,
yeah. So a couple of questions we have in the chat are from Naomi. She asked, is it normal for parents to access pulmonology and palliative care teams after hours? And then she also adds, especially for a child that needs a trach, yet families that decline the trach and child's on comfort care. I mean, I'll say from personal experience, once Zoe was on like comfort care and with her palliative care team, and not necessarily on hospice, they're very responsive to us, palliative care. It would be maybe not middle of the night, but if I needed to talk to someone, it'd be a Zoom call the same day. So, but yeah, Dr. Caylan, if you want to add to that.
So for like our service now in my department, we have someone on call 24/7, and it has been like that on every hospital I have been as the pulmonology service. I even got calls from patients like got the wrong dose of seizure medication because they thought that it was easier to reach the pulmonology V answers.
You guys got back quicker.
Yes. Yes, and whatever you need, and like you have a question about like respiratory needs of the kids, yes, you can reach the pulmonology. And I'm pretty sure with the palliative care from my like husband that they are willing to talk to you whatever time you need to talk with them.
Yes. And then she also asked about this, and I was thinking about this too,
Mhm.
is how do you interact and what choices do you give to single parents or even maybe people without a support system,
Mhm.
and also that live maybe in an area where nursing isn't an option or not a reliable option, to have a second person that can be trained.
Yeah. So this becomes challenging actually. So there were times that we had to have like conversation about the tracheostomy. Is it really reliable to have one caregiver and a tracheostomy for a patient? And like there were times eventually that single parent showed like agreed that this is not manageable. But there were times that also I had one mom like single mom and not no one, like, because it doesn't have to be two parents. It's like it can be a grandparent, aunt, friend, someone, but that single mom did not have anyone and eventually went home with just one caregiver. But acknowledging the risk. So like when you are like if you don't have the nursing care, it's you and it's 24/7 you. And there is increased risk if you're not available. Like you need a break. The worst case, you're gonna need a like restroom break, and that means that there's no one. So of course there are times that the nurse is also not right at the bedside. But just to understand that risk, I think it is going to be an acknowledgement and accepting that risk before doing the procedure.
Yeah. No, that's so important. Okay, Gabi, she threw out a question. She said, I think we jumped into this a little bit, but if anyone wants to share more about how quality of life shifts before and after the trach, do some things become less or more easy with a trach?
I'd love to jump in.
Sure.
So for Hudson, personally, a lot of his airway was positional. It got to the point where it didn't matter what I did, how many neck rolls I made, how many little pillows I bought to help position. We couldn't tolerate the car seat. And if you can't tolerate the car seat and you're 2 hours from the hospital, it's not, it got to the point where we couldn't live that way anymore. We couldn't go to therapy, which hurts his quality of life, right? We couldn't go see our specialist the way we needed to. It required more oxygen, things like that. And that doesn't mean you don't need oxygen when you have a trach. Hudson still has oxygen occasionally, but what I'm saying is his position doesn't really matter so much anymore. We're able to tolerate the car seat now because that airway is always pretty much open as long as that trach is where it needs to be. It's strapped right. It's not coming dislodged. Then he's breathing. He's doing good. So like car rides are easier for us. Being able to access care is easier for us now and safer because I don't have a nurse. So I am driving 2.5 hours by myself. With Hudson, and it needs to be safe. And for us, the trach did offer that sense. I think Brittni said a while ago that it kind of offered stability, and it did for us too. It offered me being able to care for him safely. And then I also wanted to say something about I'm not a single mom, so I won't understand what you're going through at all. But I do want to say before I left, I made sure with our training, I made sure that the doctors, whoever was training us, taught me how to do a trach by myself if I was all alone. So if Hudson's trach came dislodged, no one was at the house with me. I wanted to know how to do it because when they teach you, you have two hands. They want you and whoever else or another nurse to be there. I wanted to know how to do it without anybody else at home, just because there's times my husband's traveling, my mom can't always be here, we don't have a nurse. So I think if you are a single parent or someone who is alone a lot with your child, like me and Brittni are, I think it's very important to ask for you to be trained by yourself, where if someone's not with you, and you are comfortable taking care of your child without someone there. There are risks, absolutely. And like the doctor said, you know that going into that. But I think that's very important to remember is, learning to change the trach on your own if it was to come dislodged in some sort of emergency or something like that. Hudson got a tooth stuck in his one time. So that was very interesting. Yeah, our ENT was like, I've never seen that before. Please send me a picture. But yeah, so anyway, you never know when you're going to have to change it. It's not always on the day that you've set to change it. So knowing that's very important. So I did want to add that.
Brittni, I'd love to hear from you about quality of life before and after.
I feel like this is a big, big one because we, right before the surgery, he was BiPAP at night, which had its own struggles. He has, his mouth's physically not fully able to close. He had to only wear a nose mask because of his high risk of aspiration and all of that. So that came with its own struggles. We had a lot of skin issues and stuff, but he was on room air during the day. So we went in for a procedure that we knew what to expect because we had it before, and then went home. He's now 100% vent dependent. So he has so much stuff. but I think, perspective wise, like it's safely given us more time with him, and it's given us his ENT was the one on to do the surgery, and she was like, well, we've struggled for years with secretion issues, and this is now when, when she was going through all of the different, things that we use all of that. We actually have an IPV instead of a vest because of his wound issues, which is similar kind of like internally, but cough assist I use all the time. So like it's changed in what our day to day looks like, but there's also this level of I don't know if comfort's the right word, but that he like I know that I've got and I've had to use it more often than I wish, but like I have an ambu bag that I'm able to give him breaths, when he desets to numbers I don't like. So I've learned a lot. It's a big shift. And I think, because he does, going out is a huge thing because he does still need the vent and he needs oxygen and all of the things. But there's like we had said, and Lindsay said too, the stability is there. So it's different. It's heavier in a lot of ways, but he's safe. And I think that's the biggest takeaway. So
Yeah.
yeah, it was hard how we got there, but now that we're here, I'm grateful and that we have the tools that we have to keep him as safe as we can. So
Yeah. Well, I appreciate everyone sharing. And Dr. Caylan, you have anything else to add? I'd love to give you one more opportunity and then I'll say bye.
Well, thank you so much for giving me this opportunity.
Yeah, it's been great. And just so everyone knows, here, I'll share my screen one more time. Um, this will be on our website as soon as possible. And feel free to tell us how we did today. You can scan the QR code, join our mailing list. I mean, honestly, I already have your email, so I'm going to add you to our mailing list after this webinar. But it's a great our mailing list goes out we do a newsletter once a month that has our upcoming webinars. We also do we call them deep chats where we have support groups where you can kind of just sometimes I have a topic, but a lot of times we just hang and talk about how your kids are doing, what struggles you're having right now, just be a support to each other, which is really great. But yeah, we've loved having everyone, and it's so informative and great. Please share with all your friends who would benefit. And yeah, it'll be on the website soon and the recording.
And
And we'll
I
also,
think
oh,
there
I'm
is
sorry.
one question. Sorry,
Oh,
I
yeah.
wanted to catch you before you like close
Yes,
up.
please.
I think Naomi asked what mental or emotional support is given pre-post decision.
Oh, yes. I love that.
And like please feel free to answer, Lindsey and Brittni, but like palliative care team is a big support here. And they like not only talk with you about the like medical decision, and they will talk all more about like the day-to-day life, quality of life. And then they have in our um, team, in our palliative team, they have a clinical therapist also, which will meet with the families. So
Yes.
they are a very big support on this part.
and I will pick it. That was very similar for us, palliative care. We also have a complex care team, and so they have a social worker too. And I really felt super supported. Even our trach educator, really took the time when we were learning things to go through all of the things, the feelings and because when you're having to make decisions very quickly and all of that. So yeah, and then I think I just have to say thank you for me too, to have a place where you feel like seen, when you have such a complex child. It's difficult. So I'm very grateful for DEEP and everything that there are resources outside of your hospital, because being able to talk to a caregiver, a parent, a mom who gets it is just everything. So
Yeah. Living it every day is different than,
mhm.
yeah, doing the surgery and being sent
Yeah.
home.
Yeah.
So it's a whole thing. But, and you guys all have different experiences and different, I mean, I think all of us medical moms need a honorary PhD, but,
We
but
do.
yeah, we've learned our lessons and, in life and, um, yeah, yeah, it's amazing. I think, yeah, medical moms are superheroes and, I was reading this one last thing. Yeah, palliative care. I'll sing the praises forever. I wish we've done it from day one with Zoe. It took us many years to get there. But yeah, they're amazing and such a support. But like I said, loved having you all, and everyone will be recorded. And yeah, we'll also I'll probably grab Dr. Caylan's slides too, just to have, so it's like a quicker thing. And then we normally always make like a quick guide that we put on social media for everybody. So. Yeah, thanks so much, everyone, for taking the
Thank
time out of
you.
your day.
Thank
And
you. Thanks for having us.
yes,
Yes.
thank you so much, everyone. Okay, bye. Have a good Thursday.